See this stuff in here? It's not a true gland filled with luminal material. This is central necrosis. So this tumor is growing and proliferating so rapidly it's outgrowing its blood supply. So it's having all these little pink areas. There's one here. Let's see if we can find some more. There's one. So this is not a gland. This is a little island like this of tumor that's gotten so big it's become necrotic in the center. Okay, see there's some more. So you're right in that it's tumor. Now let me show you this. So here is a clue. Let me go back here. Okay. So do you see this squamous mucosa? Let's go up a little bit higher. Basal layer. Here would be the lumen. And see how these look pretty much normal, right? Kind of as they get toward the surface, they get mature, the nuclei kind of flatten out, and they'll eventually disclimate off, and then they'll be replaced by others. But if we go along, let's keep going. Okay, let's keep going. What's starting to happen here? This doesn't look right, does it? What about that? So this is dysplasia. See how this looks different from that? Let me go to a higher power. Remember that last one we said was reactive atypia? Look at how big and dark these are. And they still do have some cytoplasm, but in some places they're starting to pile up on top of each other. Can you see that? These look very different from those others that have reactive atypia. And it's from the basement membrane here all the way to the luminal surface. So this is the full thickness of the squamous mucosa. So this is carcinoma in situ. So this is a precursor lesion to this. Where'd it go? That's the wrong way. To that. So can you see this is our squamous mucosa, and here's cancer coming right off that. So this is invasive squamous cell carcinoma of the esophagus. Where does this usually occur in the esophagus? So the middle, the distal portion of the GE junction, the proximal portion. Does anybody know? I'm sorry? Yes. So squamous cells usually occur in the more proximal portion, whereas adenos are more in the distal portion. Okay. And you can see, let's go over to this piece. And see all that necrosis? Okay. Now, let's see what else. We talked about the lesion, we talked about the in situ area, we talked about the invasion. It's kind of, while it's kind of occupying this whole end, it's not through down here through the deeper layers, so it's kind of still in the upper third or superficially invasive still. But invasive is invasive. You're going to have your esophagus radiated and removed. Let's see. Okay, what about desmoplasia? What's desmoplasia? Does anybody know? Right. So it's activation of fibroblasts that kind of elicits kind of like a scar-like, here's some. Kind of like a scar. And it's like the body, the tumor elicits things because they're bad cells, right? They're trying to invade. And they're eliciting all these things to try to go into the stroma. And the body's trying to wall them off. It's trying to scar off a wall. And it kind of gets this gray-blue appearance. And that's kind of a key when we're looking at something going, well, it looks funny, but is it invasive or not? If we see that, that's a clue that it's probably invasive. Because that doesn't happen in any other situation. Okay. Then it talks about lymphatic invasion. And let's see. Is this one? Let's see. Lymphatic invasion can be tricky. No, I think that's just contraction artifact. So if you go, here might be some. So tumors get into lymphatics, and that's how they disseminate throughout the body. And so these areas, when you see these little tiny balls in these little spaces, this is suspicious for lymphatic invasion. Sometimes you can see a little flattened endothelial cells of the lymphatics, and that helps you. Sometimes you can actually do a special immunostain to highlight those cells and kind of make certain once and for all. That's suspicious for sure. Okay, what else? What predisposed, what are risk factors for squamous cell carcinoma? Smoke. The answer is always smoking and drinking, right? All the fun things. So, whoops, ooh, what did I do? Don't know how I did that. Okay, so those are the big ones. The treatment, it's a little bit different. Radiation. You can, so if you have adenocarcinoma of the esophagus starting from Barrett's, the treatment can be radiofrequency ablation. It can be a little bit of mucosal resection, but a lot of places now are going right to esophagectomy. Squamous cells you usually radiate and then resect. Squamous cell carcinoma is sensitive to radiation. Adenocarcinoma is not. So that's why. Okay. And signs and symptoms will pretty much be the same. You're just going to have some pain, difficulty swallowing, maybe an obstructing mass, you know, if it's big enough. Okay. And incidence in the USA, which is higher, adenocarcinoma or squamous cell? Adeno, right. Okay. Does anybody have any questions about the squamous cell carcinoma? Okay.
Question.
Yeah.
How do you go from, what's the dividing line between high-grade dysplasia and carcinoma that is different, what makes it one and not the other?
Right. So, it's essentially the same thing. So, if you have the full thickness of the squamous mucosa, very atypical like we saw, it's high-grade dysplasia, but when it's the, so you can have it if it went up like 2/3, that would be high-grade dysplasia. If it's the full thickness, it's carcinoma in situ. But if you look at the cells, they look exactly the same. It's clonal. So, and some people do use them interchangeably. Okay, but I mean they're both precursors to invasive cell carcinoma. Good questions. Okay, let's do number 4.